Okay. So to begin with, I want to talk about the anatomy of the system, or actually, let me say this. What I'm planning on covering today is sort of three different aspects of things, which is to look at the anatomy of the respiratory system and then consider the functions first in how breathing works, and then how gases are exchanged in the body. To start that out, however, let me just lay out the functions of the respiratory system. First off, there's ventilation, which is breathing, getting air in and out of our lungs. And then there's external respiration, which is gas exchange between air and blood. And then once the gases are in the blood, they're transported. So there's gas transport. And then we have internal respiration, which is gas exchange again, but now it's between blood and tissue. And then finally, there's cellular respiration. Now, actually calling this functions of the respiratory system is a little misleading, because really the only things that are localized to the organs of the respiratory system are ventilation and external respiration. Once gases have been exchanged from the air to the blood, they're transported through the cardiovascular system out to all the various tissues of our body, which is where internal respiration takes place. And then cellular respiration is just talking about sort of the underlying chemistry behind having these gases on hand. Really, cellular respiration is one of a few things that will tie this system with the digestive and urinary systems. So those three systems together in the book are a unit that's energy, maintenance, and environmental exchange. Energy and maintenance is fine. It's the environmental exchange thing that's really defines us all together. I mean, we could say energy applies to, musculature, and maintenance applies to the regulatory mechanisms of the nervous and endocrine systems. But environmental exchange is really what we're talking about, getting things from the outside world into our body, and again, getting the wastes out of our body. That's happening across all three systems. So there's actually 5 chapters in here. There's the respiratory system chapter, which is what today's about. Then next week, we're doing the digestive system, and I want to talk a little bit about metabolism with that also. And then the week after that, we're going to be doing the urinary system and a little bit about fluid balance stuff. Now, as far as chapter assignments are concerned, we're doing 1 set for this week on the respiratory system, 1 set next week on the digestive system, and then 1 set the week after that on the urinary system. And then the final week will be the reproductive system, which is the next unit. So the chapters, metabolism and nutrition, and the fluid balance chapter are extensions of what the digestive or urinary system are covering, but going into other details about it. We're not going to do those chapters specifically. There were Learning Pod assignments for those chapters, which if the Learning Pod thing was working the way that I intended this semester, you'd be doing those with those during those weeks. But you may have already done them for the extra credit assignment, But we're not really going to be dealing with those chapters much, other than how they fit into the digestive or urinary systems when we get to those weeks. Okay? But there are some things that tie these three systems together, and one of those is cellular respiration, which is usually depicted with the chemical reaction C6H12O6 plus 6O2, whoops, I keep doing that, O2 yields 6CO2 plus 6H2O. Okay, didn't do that right. H2O. So in what I'm using here to put things up on the screen, typing in them, I can't do subscripts. So of course the 6, 12, 6 in this, and the 2, and the 2, and the 2, and the other ones would be subscripts, representing how many atoms there are of each of those elements in each compound. And then the 6 before oxygen and before carbon dioxide and before water is just that for a single molecule of glucose, which is what C6H12O6 represents here, for a single molecule of glucose, we would need 6 oxygens, and we would generate 6 carbon dioxides and 6 water molecules. That just balances all of the atoms on either side of this equation. Now, this reaction is often described as referred to as cellular respiration. The idea here is that in your cells, this is how we get energy out of glucose, and it depends on bringing oxygen in and releasing carbon dioxide as a waste product. So that's the respiration part, oxygen in, carbon dioxide out, which is what we often associate with breathing. So the respiratory system functionally is really trying to get oxygen into your system to use for this reaction, and then clear carbon dioxide out as a waste. But this also kind of points at the other systems. Glucose, or any nutrient molecule, is getting into your system, ultimately through the digestive system. And then water as a waste we get rid of through the urinary system. So that kind of ties all of those together. So that's kind of an overview of where we're going with this. Like I said, what I want to talk about is the anatomy of the system, and then concentrate on how breathing works, and then concentrate on how gas is exchanged. In the book here with the organs of and structures of the respiratory system, it describes the conducting zone, and then a little while after laying out all those parts, talks about the respiratory zone. The conducting zone is basically the pathway that air takes in and out of our body. So that's sort of where ventilation goes. And then the respiratory zone is where external respiration takes place. Okay, so as far as the anatomy is concerned, what I'm about to cover, we're basically only going to cover the structures that are related directly to ventilation and expiratory respiration. The other parts of what's in here, gas transport, internal respiration, and cellular respiration, are not happening in the respiratory system. It's blood is transporting the gases through the cardiovascular system, and then internal respiration takes place in all of the tissues of your body. Cellular respiration is what's happening within all the cells of your body there. Okay. So to describe these I actually want to go to using the models over here, which is slightly unfortunate for the recording. So I'm going to try to kind of keep up with the pictures in the book here a little bit. So like I just said, the book presents it as the conducting zone and the respiratory zone. But I'd rather present the anatomy as an anatomist more in terms of the upper and lower respiratory tracts. And a lot of sources will define those pretty simply just as what's in the head and neck versus what's in the thoracic cavity. But it really should be defined a little bit better than that. The defining feature, I think, that separates upper and lower respiratory tracts is really what keeps the respiratory tract open. You want to keep the tract open all the time, or as much as possible, so that you're always getting air moving in and out of your system. And so the upper respiratory tract should correspond to parts of the body where it's kept open with bony structures, which would really mean structures of the skull and then coming out of the skull and the neck a little bit. And then the inferior respiratory tract would be structures that are kept open by cartilage. If we're to say head and neck is where we have upper respiratory, doesn't quite work because right here where we see this light blue coloring, that represents cartilage, which would make this part of the lower respiratory tract. So I am going to make that distinction a little bit. And the book doesn't go into upper and lower respiratory tract. It talks about the conducting and respiratory zones. And the conducting zone is really the respiratory tract. I'm going to, at the end of the respiratory tract, because it's where the air ends up, talk about the structure which the book is referring to for the conductive zones. I don't have models of that because it is microscopic. But now we're going to follow the respiratory tract based on the direction, based on the path that air flows when you breathe in. And then when you breathe out, it just goes back the opposite direction. So we can breathe in through either our nose and our mouth, but we're going to focus on the nasal cavity because a lot of the structures in the oral cavity are really about digestive function. So we'll be dealing with that next week. The opening to the nasal cavity, as they pointed out here, is the nostril. Another term for the opening of the the nasal cavity is the nares. And nares is singular, nares is plural. And so some sources will kind of say nares and nostrils are the same thing. It's not exactly the same thing. The nares are really the openings like we see in the skull, so the nasal cavity. The nostrils are just going to be the fleshy openings in the external nose. There are actually 4 nares. There are 2 external nares, which are the openings to the outside, and 2 internal nares, which are the openings from the nasal cavity onto the next part of the respiratory tract. So especially if you think about the internal nares, which are definitely bony openings here, the external nares kind of make sense on that side. But in the book, they're just calling it the nostril, which is fine. It's not crucial that we call it the nares. That's just the more formal name for the opening there. Around the nasal cavity, it's defined, like I said earlier, it's kept open because of bone. So I want to just quickly run through the bones that we find here. The forehead is the frontal bone. A little bit of that makes up part of the roof of the nasal cavity. And then as we move back, the ethmoid bone is the next region in the roof of the nasal cavity. The ethmoid bone is also going to be the bony part of the nasal cavity, sort of represented by these 2 big structures here and other bones that aren't visible because they're more in a midline position. But that's the ethmoid bone. And then as we move back, right about here is the sphenoid bone. And then between the sphenoid bone and the other side of the internal nares is where air moves on into the rest of the tract, which we'll get onto in a little while. The floor of the nasal cavity is the roof of the mouth, the palate, which is made up of 2 bones. One is the palatine bone, which makes up about the posterior third of the hard palate. And then the front part is the maxillary bone, specifically the palatine process. The maxillary bone also extends up to make part of the wall of the nasal cavity here. So I point out these two structures at the top we associate with the ethmoid bone. The one at the bottom is the part of the maxillary bone. Those structures are little protrusions or wings of bone sticking out from the lateral wall with little grooves in between them. The bony structures sticking out are called conchae. Concha is singular, conchae with an E on the end is plural. There's the superior concha, the middle concha, and the inferior concha. The inferior concha is part of the maxillary bone. The middle and superior are part of the ethmoid bone. Then the grooves in between these, or below the inferior one, are called meatuses. So there's the superior, middle, and inferior nasal meatus. And they're on either side of the nasal cavity in the lateral wall. They work as kind of turbines. When you inhale air through your nose, that sound that you hear is really the air kind of spinning within the structures of those conchae, which slows down the passage of the air. The air moves a little slower through the nasal cavity because of those. And what that allows for is that the air can be heated up and hydrated. The air outside of us, atmospheric air, is colder and drier than what we want in our body. So as it passes through the nasal cavity, the conchae sort of spin it around a little bit in a turbine fashion to slow it down so that it can be hydrated and heated up. And both of those things happen because of the nasal mucosa. Question? Would those help with the removal of like debris and pathogens? Well, not those specifically, but the nasal mucosa does, okay. Yeah. So the nasal mucosa is a pseudostratified epithelium, and then its associated connective tissue. That connective tissue has a lot of blood vessels in it, which the blood there will heat up the air as it's going through. And then the mucus that's produced in the pseudostratified epithelium has water in it, which will hydrate the air as you breathe it in. Okay. Also, that mucus is going to help with trapping small particles that you inhale, whether they're airborne pathogens or dust or pollen or whatever, going kind of to Kirsten's question. But as for what the air is doing there, it's hydrated by the water and the mucus, and it's heated up just because of the temperature of the blood there. If you take a deep breath like that, you can kind of feel a little bit of a cold burn in your nasal cavity when you take a deep breath. That's because the air is colder than your body temperature. But you don't really feel that past your nasal cavity too much. Now, as I've been doing this for other classes, I've said, well, finally, we're to the point of the year where you don't have, when you go outside, you take a deep breath, it's not as cold. Thank you today for being different. So if you go outside and it's still kind of cold out there, you take a deep breath, you're going to feel the cold really going down further into your respiratory tract. And that's just because the colder the air, the longer it takes to heat up to body temperature. So you can really feel that wintry kind of air deep inside the system. Now, from the nasal cavity, we move into the pharynx, which is what we call the throat. And the pharynx has three regions. They're named for what they're adjacent to. So adjacent to the nasal cavity is the nasopharynx, which the inferior boundary of that is basically the tip of the soft palate. So where I have my finger with this model here, that's the nasopharynx adjacent to the nasal cavity. In the nasopharynx is the pharyngeal tonsil, which is perfectly situated for assessing airborne pathogens that might be trapped in that mucus as the mucus moves across the pharynx. Also, there's this little sort of puckering looking thing in the nasopharynx, which is represented right there. That's the opening to what's called the auditory tube. It's also known as the eustachian tube or the pharyngeotympanic tube or something like that. I just prefer auditory tube. It's a connection from your nasopharynx to your middle ear. Now, your middle ear is separated from your external ear by the eardrum or the tympanic membrane. air pressure on either side of that membrane should be equal. If it's not, if there's higher pressure in the middle ear than the outside, then the tympanic membrane will bulge outward a little bit. And if there's higher pressure outside than inside, then the tympanic membrane will bulge inward a little bit. The auditory tube gives you a chance to equilibrate the air pressure across the tympanic membrane. It doesn't happen directly between the external and internal middle ear because it's sealed off there with the tympanic membrane. So instead, when the auditory tube opens, air from your respiratory tract can get into your middle ear, or air from your middle ear can get out to the respiratory tract, so that the air pressure equalizes between your middle ear and the outside air pressure. You've probably had experience with this sort of thing happening. The most common example of it is if you go on a plane. When you get on the plane, you're getting on at your sort of sea level kind of air pressure. We'll talk about air pressure later on, but we're going to generally assume air pressure at sea level. Okay. So you get on the plane there in Hartford or Logan or whatever. I guess Logan would be a great place for sea level air pressure. And then when the plane takes off, they lower the cabin air pressure because the air pressure outside the plane at 30,000 feet is much lower. And there's less stress on the walls of the airplane if the air inside is a little bit depressurized. So they lower the cabin air pressure as much as they can. And you can feel that when your ears start to hurt when the plane takes off, because the air in your middle ear is at the pressure of sea level, and the air outside is this reduced pressure in the cabin. You just have to do something to open that auditory tube. It stays closed because it's got a little bit of elastic cartilage wrapped around it, and any pharyngeal muscle movement will actually pop that open a little bit so that air can move quickly in and out and equilibrate the pressure there. So when I was a kid and we'd go on the plane, my mom would give me gum, so I'd be chewing and therefore swallowing the saliva, and that would help keep my ears from getting blocked. And for some reason, she told me that when you're landing, which is when the opposite's going to happen, you have to yawn for it to work. And I think that just means that when I was a kid, I was really tired at the end of the plane flight, so I was yawning all the time. And she was just saying that so that she didn't have to give me more gum. But whatever it is, any kind of pharyngeal muscle movement will cause the opening to the auditory tube to pop open, and you can equilibrate that. You don't have to go on a plane to experience that. You can drive up a hill a little bit and feel that. If you really want to experience this, get on the Pike and drive towards Lee. Somewhere between here and Lee, there's the highest point on the Pike. It's like 1,200 feet above sea level or something like that. I don't remember. There's a sign that says it. And just as you go from this level to that level, the air pressure will change enough that you'll feel it in your ear. Yeah.
Let me just backtrack. Right after the conch, you mentioned the meatus. Is that an opening to? Usually, meatus is opening, but in other contexts.
It's not a hole. It's the groove between the conch. So this is a conch. This is the meatus, just the groove right underneath it. So that's the nasopharynx. Once we pass the tip of the soft palate, we go into the oropharynx, which is adjacent to the oral cavity. We see a shift in the epithelium lining that space. When we get into the oral cavity, the oropharynx, it's going to be continuous to the oral cavity, which is lined with a stratified squamous epithelium. Now, when you hear stratified squamous epithelium, you should immediately, reflexively, think of what word? No. If that were true, you'd be really disgusting. Mucus all over the place. Yes, it is in your skin, but it's in other places too. Everywhere that we find stratified squamous epithelium, it's there because of what function that it's primarily for. Protection. Okay. So when you hear stratified squamous epithelium, think protection. Okay. We'll do a little call out. Stratified squamous epithelium. Protection. Stratified squamous epithelium. Protection. Pseudostratified epithelium. Not protection. Okay. That's the point. Your nasal epithelium, pseudostratified, is not very protective. So if you're going to do something like drink hot tea or whatever, the stratified squamous epithelium is going to protect against that high heat, if you will. If you were to drink some tea and then start laughing and it goes up into your nasal epithelium, that's going to sting a little bit, okay, because it's going to burn through the epithelium a lot quicker. Okay. The bottom of the oropharynx is the tip of the epiglottis, okay, which actually moves depending on what's going on with swallowing, but it's essentially what's adjacent to the oral cavity there. And then from the tip of the epiglottis down, we have the laryngopharynx, which is adjacent to the larynx. Now, the opening of the larynx is right here, but the laryngopharynx continues on down adjacent to that until it meets with the esophagus. So once we get past the opening of the larynx, the laryngopharynx is really strictly digestive tract. But the oropharynx and the top of the laryngopharynx is where the digestive tract and the respiratory tract cross over. And we need to have the more protective stratified squamous epithelium there for digestive function. Once we get into the lower respiratory tract, which we get to at this point, we're going to switch back to the pseudostratified epithelium. It's actually not going to happen immediately. The pseudostratified epithelium is really going to start in after we pass the vocal cords. The vocal cords can close off. If you hold your breath, you're basically closing off the vocal cords to stop the respiratory tract, which is not something you want to do for a long time. But it's a good way to stop anything from getting down into the respiratory tract. The epiglottis does that automatically, but the vocal cords you have voluntary control over. Yeah.
So the interface between the stratified squamous epithelium and the pseudostratified epithelium.
What do you mean by interface?
Well, just kind of where stratified epithelium and pseudostratified epithelium meet, demarcating the oropharynx from the laryngopharynx.
Well, not between the oropharynx and laryngopharynx. They're both stratified squamous epithelium. But between the nasopharynx and the oropharynx, you'd see a transition there. And it would be very abrupt. It would just be pseudostratified, stratified squamous. Okay. When we're looking at the digestive system, we're going to see a similar transition when we go from the esophagus to the stomach. Not pseudostratified, but simple columnar. And looking at it under the microscope, it's just abrupt. It's like one just right up next to the other. Other places we do see sort of transitions where we go from one slowly into something else. But for these, there's going to be an abrupt transition from the nasopharynx to the oropharynx, and then out of the laryngopharynx into the larynx. We're going to see a fairly abrupt transition between them. So that brings us into the lower respiratory tract, which is starts with the larynx right here, which is what we see in the head and neck model. But this other model over here shows us the rest of the lower respiratory tract. So the larynx at the top here, and then the trachea going down from that, which branches into the bronchi that branch further and further within the lungs. So this model kind of shows all of the lower respiratory tract, and it's predominantly this light blue color, which is what we associate with cartilage, because that's what's really keeping everything open. Now I have this other model here that shows the larynx in a bit more detail. And actually, let me switch to a picture of the larynx. So there's a little diagram showing the different regions of the pharynx. Too far. Okay. So let's take a lot. There we go. So here's the larynx. It does have a bony structure right at the top, which is the hyoid bone, which we see in this model at the top. That's the only bony part associated with these structures of the lower respiratory tract that I'm talking about. Does anybody know what's unique about the hyoid bone compared to all other bones in your body? I don't know what that means.
That
would be the atlas. What did you say, Jen? Yeah, it doesn't make a joint with any other bone in your body. Okay. The little bones in your ear, the incus malleus and stapes, make joints with each other, but nothing else in the body. But this does not make a joint with any other bone in your body. It's only connected to soft tissue. So in this model, we can see some dense connective tissue that's attached to. Also, it's attached to a lot of muscles. For instance, the hyoglossal muscles go from the hyoid bone to the tongue, which is what glossal means. And as you're moving your tongue for speaking or swallowing, mostly swallowing, the hyoid bone will move with that. Okay. Now, you can't exactly feel the hyoid bone, but it's located right at the transition between the bottom of your jaw and your throat. You can't feel it because it's got a bunch of muscle tissue covering it. So you can feel sort of the belly of the muscles that are right on top of it, right about here on the side. But you can't actually feel the bone itself. I asked this question, when was that? I guess it was Tuesday night, about what's special about the hyoid bone. And one of my students said, it's what cracks when you strangle somebody. And so I went, okay, and we just moved on from there. But if you watch CSI, they'll often say, well, we know it was strangulation because the hyoid bone is fractured. So whatever. The rest of the thyroid is made up of cartilage. The major piece of cartilage is called the thyroid cartilage, which we see here. And it makes up really the wall of the so-called voice box. It's only making up the wall anteriorly and laterally. There's not any posterior thyroid cartilage, but it really sets up a resonant cavity where the voice sort of gets its tone from. The bigger the thyroid cartilage, then the deeper the voice would be, which should immediately make you think that obviously men have larger thyroid cartilages than women. There's some sexual dimorphism there. Now, where the thyroid cartilage comes to kind of a point on the anterior midline right here, this is the laryngeal prominence, which is the Adam's apple, okay? And you don't really see an Adam's apple in a woman's throat. That's why it's not called Eve's apple. And that's because the thyroid cartilage in men is bigger, so it's protruding a bit more. And I think this past weekend or something, I was watching a Harrison Ford movie, and I was noticing he has a huge Adam's apple. It was, I think, Regarding Henry was the movie, and he was laying down or something, and I was just noticing that he had this huge Adam's apple that was moving back and forth. And probably because of the fact that he was laying down, some of the soft tissue had kind of fallen back, but whatever. So that's the so-called Adam's apple. Now, the thyroid cartilage sits on top of what's called the cricoid cartilage, which is a continuous ring all around the base of the trachea, larynx. So it's what we see here. It's a little bit taller in the posterior position than the anterior position, but it's not going to make up all of the posterior wall in place of the thyroid cartilage, just a little bit. But sitting on top of that are these two pieces of cartilage here, which are pointed out here, called the arytenoid cartilage. They actually do have a little piece of cartilage at the tip, which I'm not going to say by name because I don't care that you know that. But the arytenoid cartilage can actually pivot back and forth, okay, which this model shows a little bit. Attached to the arytenoid cartilage right there, and then anchored anteriorly in the thyroid cartilage, are the vocal cords and the vocal fold tissue there. Yeah.
Yeah, when you're ventilating somebody, particularly with using an ambu bag or bag, often, physician will say, "Can I get cricoid pressure, please?"
Okay.
Ventilation. I mean, I don't know. Anatomically, what that doing, just kind of opening the airway more. I mean, does it have a function in that regard
I'm not familiar with that clinical ramification of it. It's just, I know the anatomy. It's this base of the larynx there. So, if we look down into the larynx, we'd see an image kind of like this. This is what's called a laryngoscopic view. Okay? And so kind of going with intubating, a laryngoscope is often used to help guide a tube so that it goes into the respiratory tract, but also that it can be guided between the vocal cords, which you see in white there. You've probably seen a laryngoscope in medical dramas or something like that. In ER, quite often, if somebody had to be intubated, you see the doctor standing over the patient, and they look down through a device that they inserted in the mouth, and that would go around the back of the tongue so they could see the larynx like this. And if we look at this model here, so this is kind of what we'd be seeing. Actually, this picture would be looking at it like this, which I always feel is upside down, because that would mean that the person's face down, and it just seems more appropriate that they'd be face up. But that's the way it's in the book, and that's the way it's in another source I'm about to show you. So apparently that's okay. But you wouldn't have a person laying on their face when you're taking a picture of them, whether they're on an MRI machine or whatever. That's just an odd anatomical position to be in. But anyways, that's just to say that the top of this picture is posterior and the bottom of this picture is anterior. And in the label here, which you probably can't read, it says tongue, because that's the base of the tongue, which is coming right to the top of the larynx. And then the epiglottis, we can see a little fold right there, which in this model, that's the epiglottis there, which you can see a little bit better. Now, I have a little video I want to show you that shows the larynx in action and producing speech sounds. Where am I? Put that in the video content section here. If we scroll down here through immune system, there we go. This video here, it's on YouTube if you'd like to watch it in more depth. It's called Vocal Folds Revealed. I don't know why it's called that. I mean, it's revealing the vocal folds. I certainly understand that, but I would probably prefer myself to put a more descriptive name on it. What you're going to see is obviously a laryngoscopic view while somebody is producing speech sounds, both in speaking and in singing. And again, it's upside down. When the vocal folds are pointing, making this V towards the bottom, that's pointing anteriorly, which again just seems wrong to me, because as an anatomist, I want to imagine people laying on their back when you're taking pictures of medial structures like that. But anyway, so let me play this real quick. There is a little voiceover. You're listening to the person performing the inspection, giving instructions, and then the person who's being taped, you're hearing her too. So let me just play this out. Oh, I need to take the... So the voice that you heard there very quietly was saying, just breathe, don't choke or something like that, because they're inserting the laryngoscope a little bit deeper to see things a little better, which would, of course, stimulate gagging and coughing reflexes. So, and then they back off to a more comfortable position. A little freeze frame to show you what they saw there, but then we're going to go into actual... So while she's singing, you can see the vocal cords moving back and forth. And also, this is the retinoid cartilage. You can see that pivoting, especially when she takes a breath. They pivot and it opens the vocal folds very wide, so lots of air can move through. But when you're producing speech sounds, the vocal cords are going to be very close together because it's how they vibrate relative to each other that produces the different pitches. Okay. So you can see them kind of flapping a little bit with the lower notes in the scale she does, and she goes back down there. When she's at the high pitch, the vocal cords look like they're not doing anything. They might be kind of looking like they move back and forth a little bit, but the vibrations are at such a high frequency that we can't see it with our with the naked eye. The lower pitches, we can see the individual vibrations, but not the other stuff. Okay. That's a nice little representation of what the vocal cords are doing. In the model I have here, somebody was nice enough over the past year or so to go in and put some string and gauze pad in there to represent the vocal cords and the vocal folds. Originally, that was in this model, but then over the years, as I've been here, it kind of fell apart. So somebody came in and actually fixed it. So you can actually rotate the retinoid cartilage and see what would happen with the vocal folds there. Okay. So this is a nice little representation of that. Then we go down from the larynx into the trachea here, which is lined with rings of cartilage, keeping it open. Now the rings don't go all the way around the trachea. They're open in the back. So they're sort of C-shaped rings. What's not in this model or this picture is the esophagus, which is just going to be posterior to that, right adjacent to the posterior surface of the trachea. But what we do see here, which unfortunately is colored blue because it's sort of painted the same as the cartilage, this is actually muscle tissue making up this posterior wall. The muscle in the trachea is called the trachealis. It's a smooth muscle that attaches to the tips of all of the rings of cartilage. So they're like C's, and the muscles attached to the tips. When the muscle contracts, it pulls the tips together. When that happens all the way down the length of the trachea, the whole trachea kind of squeezes shut for a second. And that's going to increase the pressure within the trachea real quick. And you would do that reflexively if something's blocking airflow through the trachea. A little trachealis spasm is a little minor cough kind of thing to clear out what might be in the trachea. Now, what I just did to sound like a cough wasn't really a trachealis spasm because that's smooth muscle and we don't have conscious control over it. But I was just doing a shallow cough to kind of suggest what it'd be like. And thank you for giving me a deeper cough. That would be using other muscles, which is going to basically squeeze the thoracic cavity and force air out of the lungs a little bit more forcefully if you have something to get out of the whole respiratory tract there. Okay. Now, oh shoot, I don't have that. The trachea branches into the bronchi, which then branch into the lungs on the right and the left. And they form the bronchial tree. I have a picture of the bronchial tree I want to show you, which is actually the first picture in my respiratory presentation. So I'll pull that up real quick. So this figure that I used for this originally is a plastinated bronchial tree. Actually, a little bit more than that because it starts with the trachea here, And then we have the branch into the bronchi. The first branch off the trachea gives rise to what we call the primary bronchi, which go into each lung. So there's the left primary bronchus and the right primary bronchus. Once they get into the lung, they then branch again, giving rise to what are called secondary bronchi. The secondary bronchi are also known as lobar bronchi because they go to the different lobes of the lung. Then within the lobe, those secondary bronchi branch into a third level or tertiary bronchi, which go to different segments of the lung. Now, what this picture is showing is where those segments are. So the trachea and the primary and secondary bronchi are filled with a kind of translucent plastic. But then when we get to the tertiary branches here, the plastic that's injected is colored. So everything from here on out is coming off of that one branch point. And that's a segment of the lung. Adjacent segment in a different color here, an adjacent segment behind what we're looking at here. And so there are just a bunch of different regions that all arise off of one branching point off of the bronchi. What this does is it sets up a segmentation in the lung so that if something happens to airflow at this point in the lung, only that part of the lung is affected. All of the rest of the lung is unaffected. So if there's something that's blocking the bronchus at this level, then only that part of the lung's going to have trouble getting air into it. If something blocks the secondary bronchus, then that lobe is going to have a problem. If something blocks a primary bronchus, then that lung is going to have a problem. But everything else will be left intact. Okay. Now, lobar or full lung problems are pretty severe. Probably a lot of people get by with segmental blockages. They might not feel like they can get as much air as they need to. They might hear a little bit of raspiness in their breath occasionally or something like that. But it's probably not really quite enough lung tissue to interfere with everyday needs. They'll just exhaust themselves easier if they need a lot of oxygen. Okay. So this is a good representation of that. Now, what I said at the beginning, what I wrote up on the board, the functions, that's just on the figure that I'm showing here. So this is just how I'd started off the presentation. The presentation goes on to use pictures from other books, so I'm not using that. Come on. But I just wanted to show you that one picture here. Oh, I do want to show you something else in here in a second. But where did that go? No. So that's the bronchial tree. Then in the book, that sort of ends talking about the conductive zone, moving air in and out of the lungs. And the other component is the respiratory zone, which is what this picture here is showing. Here we have a bronchiole. So the bronchi branch into smaller and smaller tubes. When those tubes get down to a microscopic size, we call those bronchioles. Bronchioles do not have cartilage around them because they're so small. Other forces keep them open. But the end of the bronchial tree ends with the terminal bronchiole. Terminal meaning at the end of the line. Branching off of that is actually something that's somewhat annoyingly called the respiratory bronchiole. But it's a very different structure. It's not a bronchiole like the other bronchioles. It's actually a tube where gas exchange can take place. And then coming off of the respiratory bronchiole are these air sacs called alveoli, which is primarily where that gas exchange takes place, that external respiration. And we can see on the other side here that there's blood vessels coming in with capillaries sort of associated with the alveoli, and that's where the gas exchange actually takes place. Now in this picture, we have a red colored and a blue colored vessel here. Which is which? So blue is deoxygenated or unoxygenated, and red is, yeah. Which one's a vein and which one's a artery? Yeah, so for the pulmonary circulation, red's vein, because they're carrying oxygenated blood back to the heart. Blue is artery because it's carrying the deoxygenated blood away from the heart to the lungs. So in the pulmonary circulation, the colors are backwards from what we usually think of. So I just want to point that out here. And the gas exchange is taking place as the arteries bring deoxygenated blood to the respiratory zone to exchange those gases, and it's carried away by the red veins there. Okay. The alveoli are made up of simple squamous epithelia, which are the thin walls that we see in the micrograph here. And then in the picture, we see that here. The alveolus actually has two different types of cells making up its wall, which are simply called type 1 alveolar cells and type 2 alveolar cells. The type 1 alveolar cells are the squamous epithelial cells. The type 2 alveolar cells are specialized cells, which are still part of the wall, which is not terribly obvious right here, but we can see one right here filling in space between some of the type 1 cells. Type 2 alveolar cells aren't flat squamous cells. Instead, they're a little bit bushier. They don't, traditional epithelial cells. And their main function is to secrete a very thin fluid called surfactant. Surfactant will basically coat the inside of the alveolus, which is about the size of a little microscopic bubble. And the water tension in the surfactant helps to keep the alveolus enlarged the same way that a soap bubble would be enlarged by the water tension in its wall. Okay? There are pores between the alveoli. They're all basically interconnected within a particular region of the lung so that air can move around and inside that. Okay? There's a third type of cell in here which is not part of the alveolar wall. It's a macrophage, which are these green things we see. That's a type of white blood cell. It's there to clear out any debris or pathogens that have gotten down there. Yeah.
Yeah, the surfactant actually prevents like lung collapse.
Right, because of the water surface tension of the little bubble there. It keeps the alveolus from collapsing, and that's happening in every alveolus. So that helps keep everything enlarged.
I did have a question, kind of just overall. Within each of the lungs, one has 2 lobes. I forgot which is left or right. One has 2 lobes, one has 3, correct?
Right. Which lung do you think would have fewer lobes? Why? Yeah, because the heart's on the left side, so that lung is just smaller. Only has 2 lobes.
Functionally, is that trivial within each lung?
I mean, it just means that you have 5 lobes worth of lung tissue. 2 of them happen to be on one side, 3 on the other side.
Is it a bigger deal if your left lung collapses? Or no, it'd be a bigger deal if your right lung collapses because you have less lung capacity?
That would make sense, yeah. But when a whole lung collapses, you got some pretty serious problems going on. Yeah. People can't really walk around too often with a collapsed lung. So if that happens, they need some immediate attention. So there are probably lots of people walking around with obstructed segments within their lungs. But a whole lobe or a whole lung is going to be pretty severe. There are people that are out there, not exactly walking around, with an obstructed lobe, and that's usually because they have something like lobar pneumonia. So there's accumulation of fluid in one lung, one lobe specifically, which really cuts down on lung capacity. But a whole lung is going to be a whole different problem. So, anyways, back to the macrophages. They're white blood cells. They're phagocytic. They are there to get rid of any debris or pathogens that are down there. Debris and pathogens that you inhale should be caught in mucus. But once we're down this far into the lungs, there's not mucus. Surfactant does not substitute for mucus. The macrophages do. Mucus would normally capture those things. They dissolve in the mucus, and then you clear the mucus out of your lungs. But down in the alveoli, it's the macrophages that do that. Now, this picture isn't big enough to depict necessarily, but those macrophages come from monocytes that are in the connective tissue surrounding the alveoli. This picture doesn't depict it, but that would be true. When one macrophage has kind of exhausted itself, clearing out debris and pathogens that might get down there, it'll sort of migrate away and be disposed of. And another monocyte will move out here and become a macrophage. So this is one of the places where macrophages are the specific white blood cells we find there, because they act as this little patrol / vacuum cleaner in the area to keep things under control. So that's sort of the end of the anatomy. We've gotten the air all the way down into the alveoli. Yes?
Just one question. Now, with fetal lung development, say if you have premature delivery by a little bit, they often give steroids to promote the final development of the lung. Where does, steroids have intracellular targets, right? So, how does, I guess what aspect of the lung development is that really contributing to?
I can't say I know that much about development. I will say the little bit I do know about fetal development and the respiratory system later on, but my guess would be one of two possibilities. Steroids are usually used in two capacities. One, anabolically. So it might be stimulating cellular growth processes to finish up faster than normal gestation times would allow for. Or it could be steroids are often used as anti-inflammatories. And so that might help to reduce the amount of fluid that's in the lung, which might not be easily cleared in a premature baby compared to a newborn because the lung's not quite there. I don't necessarily know which capacity the steroids would be used in, but those are the two sort of main uses of steroids. So, and it kind of depends on which type of steroids used to do that. Okay. So again, that's the alveoli in the respiratory zone, sort of at the end of the respiratory tract. So a little bit more about the anatomy that's going to lend itself to understanding about breathing. So this is the section of the lungs, on the lungs. And here we see that there's lobes of the lungs. And there's a line across the lung right here, and across the lung right here, and across the left lung right here, separating them into superior, middle, and inferior lobes. There's no middle lobe of the left lung. So if we look at a model like this, we can see the line right there and the line right there for this inferior, middle, and superior left lobes, and the inferior and superior right. Got that wrong. 3 on the right, 2 on the left. And we can see those there. Now, the other thing to mention about the lungs has to do with a serous membrane that surrounds the lungs. So when we're talking about the heart, we already considered a serous membrane. The pericardium is a serous membrane. There's a similar thing surrounding the lungs. A serous membrane is a simple squamous epithelium and its associated connective tissue. And serous membranes tend to have 2 layers to them. One layer that covers the outside of an organ, and another layer that lines the inside of the cavity that contains that organ. So for the heart, the pericardium had the visceral layer, which was the outer layer of the heart itself, and the parietal layer that lined the inside of the mediastinum. For the lungs, we call this the pleura, and it has a visceral layer, which is the outer part of the lung, and a parietal layer that lines the inside of the rib cage. Now, the rib cage obviously has ribs in it, which is the bone that's right in the middle, but then between the ribs are muscles, which are called intercostal muscles. And together, all of that will make a solid wall to the rib cage. And so the parietal pleura lines that inner wall. And then it lines the superior surface of the diaphragm, and then it's going to be adjacent to the mediastinum stuff. That's where the pericardium is. Between the two layers, just like in the pericardium, there's little cavities. Here it's called the pleural cavity, and it's filled with fluid. That fluid is going to help to lubricate the lungs as they might move across the surrounding structures, just like happens for the heart. But the pleura has another important function, which is it helps to kind of stick the lungs to the inside of the rib cage. It's not exactly what's happening. That's sticking there. But instead what it is because this pleural cavity is a closed cavity. If you try to pull the parietal pleura away from the visceral pleura, you won't be able to do it. Okay? The best way I can kind of illustrate this is imagine you have something that's wrapped in shrink wrap, and you want to try to pull that shrink wrap off. Okay? You can't get your fingers around the shrink wrap very well because there's no space between the shrink wrap and whatever it's wrapping. Okay? So if you pull on the shrink wrap, it's going to want to pull away from the thing, and as that space increases, the tension is going to get higher and higher. Okay? For the lung, since it's soft tissue, when you pull the parietal pleura away with the rib cage, the visceral will come right with it, and the lung will expand when the thoracic cavity expands. And that's the basis of what enlarges the lungs for breathing. When you're breathing, you're expanding the volume of the thoracic cavity in a couple of ways, which I'll talk about in a second. And the lungs will expand within that cavity because of that relationship in the pleura. As the wall of the rib cage expands out, it'll pull the lung with it. When the diaphragm contracts and it'll move down, it'll pull the bottom of the lung with it, okay, because of the pleura there. So to talk a little bit more about what's going on with breathing, the next section, the process of breathing, is talking about that. And the first thing to understand about this has to do with the relationship of pressure to volume. So just enlarge this for a second. This equation says something actually seemingly very simple. Pressure and volume are related to each other. If we look at a system at two different times, the product of pressure and volume has to be equal at both instances. So that's said here, pressure 1 times volume 1 has to equal pressure 2 times volume 2. And so we see that in the picture down below. And this is what's called Boyle's law, that pressure and volume are tied together like this. So here we have a beaker that we've trapped some air in. Okay? And we put a lid on the beaker so that we have a liter of air, let's say. And that air that we've trapped in there is at 1 atmosphere of pressure, what we would find at sea level. The pressure that we would feel of the air against or that we could measure of the air against the container wall comes from the little particles, the molecules of nitrogen or oxygen or carbon dioxide or water or other trace molecules that are there, or particles, whatever it might be that's suspended in the air. They move around at a given rate. And each time they zip around, they're going to run into the wall of their container and bounce off. Each impact imparts a little bit of force. Okay? And as all of those impacts add up, that force together is the pressure. Okay? And so 1 atmosphere of pressure, let's say that's the pressure in here, which it technically isn't, but it's pretty close, is really, we can feel that 1 atmosphere of pressure of air on our skin because of all of the impacts of the individual particles in there. Now, we don't actually feel that pressure. We're used to that pressure. Okay? If we were to move into an environment, excuse me, where the pressure is higher, we would probably feel that increase in pressure because it's unusual. But we're accustomed to the pressure that we usually feel. Okay? 1 atmosphere of pressure. Now, the second situation here, we have the same beaker, but we've pushed the lid down so that the volume has now decreased. So if this is 1 liter in the first beaker, let's say this is half a liter over here. So considering this equation here, ooh, I got subscripts, yay. Okay, I didn't know I could do that here. So we've got pressure 1 times volume 1 equals pressure 2 times volume 2. Oh, I know, that's actually not, I didn't paste text, that's actually a picture. So whatever. So like I said, pressure 1 was 1 atmosphere and volume 1 was 1 liter. Whoops, 1 liter. Okay. What does that equal? What's 1 times 1? 1. Don't you hate it when I throw math in like this? 1 times 1 equals 1. Okay, good. That would be 1 liter atmosphere, 1 atmosphere liter, whatever you want to call that unit. The other side, we've decreased the volume to half a liter. And so what do we have to multiply that by to also get 1? What times a half will give us 1? How many halves are there in 1? 2, right? So 2 atmospheres times half a liter is equal to 1 atmosphere at 1, I mean 1 liter at 1 atmosphere. Okay. There's a relationship between pressure and volume. As volume decreases, pressure increases inversely. Okay. So if we have half the pressure, I mean half the volume, we have to have double the pressure. Let's say instead we had a quarter of the volume. What would the pressure change to then? Yeah, so quadruple up. So a quarter of the volume means quadruple the pressure. Now, we're not actually going to deal with atmospheres. Okay. The kind of pressure changes that we're going to see are very, very small. And so instead of using atmospheres, we're going to use instead millimeters of mercury, okay, which is the pressure unit that we're used to talking about blood pressure and that sort of thing. 1 atmosphere of pressure is 760 millimeters of mercury, which always kind of seems strange, okay? We're used to pressures, blood pressure or something like that, being in, you know, somewhere around 100 millimeters of mercury maybe. 760 millimeters of mercury is huge pressure difference compared to blood pressure. And again, we're accustomed to these particular pressures. So this isn't like an overwhelming pressure. It's just overall for the air, the pressure is higher than the kind of pressures we'd expect for our skin. I mean, for our blood. Okay. So instead of 2 atmospheres, how many millimeters of mercury would that actually be? $15, $20. Thank you. That's just doubling 760. We will not see this kind of pressure change. Okay? The kind of pressure changes we're going to see are going to be like 760 to 762. Okay, so if this were 762, how many liters air would be different there? And I'm not going to ask you to figure that out. But the point being, It's a very, very small change, okay? It would be, 0.09999 some odd liters. Very, very small, probably not quite that small, but a small change nonetheless. So let me just put in here, about 0.999 liters. Okay. Very small decrease in pressure, very small decrease in volume, very small increase in pressure. We're not going to actually be worrying about the specific volumes that we're talking about. Just when volume changes, the pressure will change inversely, and we can see the numbers for that pressure change, and we know that we can figure out what the volume change would be, but we don't really actually care about the real volume because we're talking about the volume of the thoracic cavity or the lungs or something like that, and we don't need to be too precise about those numbers. Okay? Just know that there's a change. Now, breathing is the result of changing the volume of the thoracic cavity. So let me demonstrate that in a couple of ways. First off, I use this skeleton. The diaphragm is located as the floor of the thoracic cavity. It curves upward when it's relaxed. The origins are all along the edge of the rib cage, and then it inserts into connective tissue that's in the middle of the diaphragm. When it contracts, those fibers are going to pull and shorten and cause the diaphragm to descend. Okay? So in its relaxed state, it bows upward and the thoracic cavity is a given volume. When it contracts, it goes down, increasing the volume of the thoracic cavity. That's really all that's necessary for the most basic breathing. Some of you might actually only be doing that. Some of you might actually be doing a little bit more than that. With the diaphragm, another set of muscles that plays a role is the external intercostals. So I said that there are intercostal muscles. There's two sets. There's externals, which would be on the outside of the rib cage, and internals, which are on the inside of the rib cage. The external intercostals, when they contract, they pull one rib closer to its next most superior neighbor. And so collectively, they'll kind of like an accordion, lift the rib cage up like that. Not nearly as much as I'm suggesting with this model here, because I'm exaggerating, but the ribs will expand a little bit when the diaphragm is going down. So the whole thing overall is going to expand the thoracic cavity space, the volume. When the thoracic cavity space expands, because of the pleura, the lungs are going to come along with it and expand too. So another way to demonstrate this is using this bell jar model that I have here. So if I take the stopper out of this, the stopper has a little Y-shaped tube in it, which represents the respiratory tract, ending in the lungs, which are the balloons here. Okay. The bell jar represents the thoracic cavity. Okay, so the actual bell jar would be the rib cage wall that's solid with the intercostal muscles. And obviously, it's plastic. The muscles aren't going to contract this. The only thing that moves is actually this latex bottom, which is representing the diaphragm. Okay. So if I move the diaphragm up and down, you can hear air being pushed in and out of the bell jar. Okay. But the thoracic cavity is not an open cavity. It's a closed cavity. So let me put the stopper back in to close off the bell jar, which will insert the respiratory structures into the thoracic cavity like that. Now, if I pull down on the diaphragm, the balloons expand. Okay? No air can get in and out of the bell jar, ideally. Actually, there's a hole in the latex, but it should. And so when I pull the latex down, as if it's the diaphragm, the only way to fill in the extra space that I've created in the bell jar is for air to get into the balloons and let them inflate, like that. And then when I push up, except when I hit the hole in, the balloons collapse. Okay, so there we've got a model of breathing, ventilation. Now, as I'm doing this, when I'm doing it right and not ripping this more, you can hear the sound of air coming in and out of this hole here, which would be the equivalent of that kind of sound, or that kind of sound. When we hear breathing, what we're hearing is just the air moving through the structures of the oral or nasal cavity. And it's just, we're hearing the rush of air across those structures. But what's moving the air in and out is really the change of the thoracic cavities down there. And the atmospheric pressure is normally 760 millimeters. That's what we'd see in the lung between breaths, when the lung's kind of back to normal size. And then when the lung expands just a little bit, the pressure drops to about 758 millimeters of mercury. 758 is a little bit less than 760, so air will preferentially move into the lungs until the pressure is equilibrated. And so now we have this expanded lung, greater volume, and its pressure has now gotten to 760. When the diaphragm and the external intercostals relax, elastic tissue in the lungs pulls everything back in. Okay? There's no muscle contraction necessary for this. It just happens naturally. Then the lungs go back to their original size, and the pressure goes up. So what was 760 in the expanded lungs goes up to 762 when the lungs go back to their normal size. The higher pressure in the lungs is going to force the air out of the lungs, and you'll exhale until we get back to 760. And then you expand, draw it in, it recoils back to its original size, air goes out. That's basic breathing. Now, as I was describing that, I said you are using just your diaphragm or maybe your diaphragm and external intercostals. I'm separating me from you because I'm doing something very different. I'm talking. Okay. When I'm talking, I'm using a lot of other muscles to control breathing. Now, what I'm trying to do is to force air across my vocal cords going out, exhalation. So there are a couple of muscles that help force air out. The external intercostals, I just said, help bring air in. The internal intercostals do the opposite. When the internal intercostals contract, they pull each rib down a little bit, which instead of the accordion going up, they're just going to pull everything down and sort of help flatten the rib cage. Also, the abdominal muscles are attached across the bottom of the rib cage right here. So kind of like a guy in a three-piece suit pulling on his tux, it'll just pull down on the, anybody? Been watching too much Downton Abbey, I'm sorry. But sort of pulling down on the rib cage and flattening it out. All of that's going to decrease the size of the rib cage and push air out. And as I'm talking, that's what I'm doing. I can sit and talk for a while and keep pushing a little bit of air out, controlled breathing like that, and keep going until I can't talk anymore. I gotta take a deep breath. Okay, so I'm slowly pushing the air out until I can't push any air out. And then I take this deep breath and I really expand my rib cage like that. So there are other muscles that do that. The diaphragm and the external intercostals will do the basic breathing kind of thing. But when you need to take a real deep breath and really expand your rib cage, there are muscles that are attached at the top of the rib cage right here where I'm pulling. The main one is the sternocleidomastoid muscle. Its origin is in the sternum and the clavicle, which is sternocleidomastoid, and then its insertion is into the mastoid process of the temporal bone, sternocleidomastoid. Notice that I said its origin is in the sternum and clavicles, and its insertion is in the mastoid. Normally, that muscle will pull its insertion towards its origin, like a muscle should. And so the sternocleidomastoid is mainly for moving your head in this direction. Both of them at the same time, you just pull your chin down to your chest. One or the other by itself is going to help sort of rotate the chin off to the side. But when you have other muscles fixing your neck in place, when you take a deep breath, the origin will be pulled up towards the insertion, and that'll help to increase the thoracic cavity volume. Also, there are muscles called the scalenes, which are attached across the first few ribs, pulling that up towards the neck. And the pectoralis minor muscles are there to help pull some of the sort of middle ribs, I think 5, 6, and 7, up a little bit to expand that. There's another set, I think they're called the serratus something or another. I don't remember exactly, but they're sort of along the sides of the rib cage, and they help with that a little bit too. But the sternocleidomastoid, the scalene, pectoralis minors are the additional muscles for inhalation when you take a really deep breath. Now, to get to know about the function of breathing a little bit more, we're going to do a little exercise today, and I want to explain that to you. I'm going to actually stop the recording because I've sort of gotten away from stuff on the screen as it is. Oh, good. All right, it didn't capture any of that anyway, so whatever.